Okay, friends and colleagues, a very good morning to everybody. I take this opportunity to thank all of you to spend your precious Saturday morning with us at the COVID-19 Academy. The session today will be discussing the topic of challenges to vaccinations in view of the third wave of COVID-19. As you all know, for the past year and a half, globally as well as nationally, we have been in the grip of an unprecedented crisis with insurmountable challenges. Lakhs of lives have been lost, the health infrastructure has been critically challenged, and frontline workers, including doctors, medical staff, nurses, and many other essential service providers, have themselves been risking their lives to fight this virus. In April 2021, we faced the second wave of COVID 19, where we witnessed perhaps the worst onslaught of this virus. With an overpressured health infrastructure, even simple things such as hospital beds, oxygen supplies, medical supplies, and ambulances became rare commodities. The good news is that today we have vaccines. Vaccines, though they had been developed earlier in the year, in March, the immunizations were low and were mainly open to frontline workers and vulnerable age groups. The bad news is that the rate of immunization so far has been far below the required rate for reaching herd immunity. The challenges to vaccination during the second wave was a little beyond, and a little beyond was mainly in terms of shortage of supplies, the misinformation being given out, and the vaccine hesitancy that kept people from getting their shots. There was also the case of the huge digital divide, which has constrained registrations, many for the underprivileged who remained unvaccinated. As you are aware, the numbers of COVID 19 infections is gradually increasing in the country. States such as Manipur, Mizoram, Maharashtra, and several states in North India have been showing an increase in Delta variants. The problems we now face in terms of the third wave are a little different. Evidence based research shows that the rates of immunization are low in vulnerable groups and especially in marginalized tribal belts. There is an alarming gap in the rates of vaccinations between men and women. Children who are said to be at risk in the third wave have not yet been vaccinated, and their other immunization programs, which were about regular vaccines, have either been halted or considerably affected, leaving children more at risk of other infections and diseases. There are also the complex emergency situations that we have faced where rescue and relief has been considerably complicated because of maintaining COVID 19 protocols. Rescue operations, including maintaining social isolation and health and hygiene conditions, have been difficult. Today, we are looking at some of these challenges and what may be the measures that can help us be better prepared. Our eminent panelists will be looking at some of the best practices and the challenges that they have faced and are preparing for. We have with us Dr. Pankaj Bhatnagar from the World Health Organization. We have Dr. Anish, who is a consultant to the Kerala Disaster Management Authority and is a professor at the Government Medical College, Trivandrum. We have with us Ms. Pratibha Pandey, who is working with Child Fund, and also Mr. Banku Bihari Sarkar, who is from the UNICEF Bihar office. So without much delay, I'd like to start the session, and we look forward to your immense insights from our panelists who are prominent players in the vaccination situation of the country. We will be starting with, unfortunately, Dr. Madan Gopal from the Niti Aayog will not be joining us today because of a prior commitment. But we will be starting with Dr. Anish, who we will be asking a question. So, Dr. Anish, if I'd like to give you the floor. Before that, I'd like to ask you the question. There is a lack of a uniform vaccination dissemination structure. Also, due to the digital divide, rural and underprivileged people are being kept from registering for vaccinations. What are some of the measures that are being taken to overcome this challenge, especially in the context of Kerala? Are there any provisions being made to increase walk-in vaccinations? So over to you, Dr. Anish.
Thank you, Jennifer. Dear organizers, colleagues, and friends. Actually, I am going to deliver a small lecture, maybe for 10 minutes, that may include this particular portion that I am asked for to discuss. So let me share my slides. Is it visible, my slides?
Yes. Yes.
I'm not telling that Kerala is a model in distributive justice for vaccination, but definitely Kerala has done some advancement in this field so that the other areas can copy, and we can discuss what are the measurements that is taken in other part of India or other part of the world, so that we can also learn from that. If you look at the distribution of vaccination in India, you will see that Kerala has done pretty good if you just measure the proportion of the total vaccinations that has already happened. If you look at the granularity of the data, Kerala has got a unique position in India. We have got around 20% of our population above 60 years of age. But in India, it is only 10%. The population proportion of elderly in Kerala is double that of India. So we got a good share of vaccination at the initial phase of the campaign because of the large number of elderly people in Kerala. But now the vaccination provision appears to be small that we are getting from the central government. Definitely, India is a very big country, and it will be very difficult for the government to distribute vaccination. If you look at the vaccination distribution, you will see that in people with more than 45-year age group, the distribution is pretty good. 70% of people got at least one dose. 36% of people got 2 doses of vaccine. But if you look at the young age, you will see that only 3% of people got 2 doses of vaccination if they are less than 45-year age group. And this is one concern that Kerala has got. I will move to some initiatives that Kerala has shown to cover the vulnerable people or in the distributive justice of vaccination. One thing is the old age homes, because we know that in some of the Scandinavian countries like Sweden, the death in COVID-19 happened at the initial phase extensively in old age homes. But Kerala, we have targeted old age homes for vaccination. We have almost covered the entire old age homes that is there in Kerala. This is actually a government order. Just you can look at the date, and it is somewhere around 10th of March. Okay, even in March itself, government has initiated extensive vaccination campaign in old age homes. That means it is just like an active kind of vaccination. That means the team will go to old age home, and we will vaccinate all the inmates present in old age home, including the staff. So that means there is no need of just online registration for these people who are residing in old age homes. Again, this is also a government order which is showing that the people who are at homes, bedridden people or palliative care patients, they have to be vaccinated and the priority should be given. And you can look at the date. It was ordered on 31st May 2021. And palliative care is another area where Kerala was actively giving vaccination, again because there is a digital divide, as Dr. Jennifer was telling already. To avoid this kind of a digital divide, especially for the vulnerable and poor illiterate people, the system was actually moving out and they are going towards the people at their homes. And if they are bedridden, they were given vaccination. And large campaign was there for vaccinating palliative care patients. You may be knowing that Kerala is a place where extensive community palliative care program is there. It is a mandatory program for all local self-government in Kerala. So many people, hundreds of people are there cared at their homes, and it may be difficult for them to move out and get vaccination from a vaccination center. And there was a dedicated program. It is almost finished, and all palliative care patients were given vaccination. This is another priority group that we were trying to vaccinate: transgenders. All transgenders are getting vaccinated, and this program is going on. And Kerala is giving vaccination preference to the people with disabilities. We have got mental health asylums or mental health institutions. We have got special schools where maybe the children, but they might have crossed 18 years, and all these people are getting vaccinated in a priority manner. So this kind of this identification of priority group or vulnerable group were done in Kerala, and they were given the priority of vaccination, and it was given through an active involvement. The people from the local hospital or the primary health center, the doctor, nurses, and other staff were used to move out with vaccination, and they were distributing the vaccine in the field. This is another program, that is Matru Kavacham. That means an armor. The word meaning of Matru Kavacham you may be knowing: armor to the mother. That means Kerala campaign for vaccinating pregnant women and lactating mothers. That is also taking place, because in Kerala we have experienced somewhere around 50 maternal mortality related to COVID. To prevent further mortality in pregnant times, we have got a dedicated program to vaccinate all pregnant mothers. That is also taking place. Another social vulnerability group is tribals. And if you look at the vaccination data, you will see that almost all individuals has got at least one doses of vaccination in tribal group. And we have got mainly 2 or 3 tribal districts: Wayanad, Palakkad, and Idukki. And you will see that these districts has got comparatively more share of vaccination. There is active campaign, and that is actually, it is not only in Kerala, all over India. You will see that vaccination campaign or vaccination program is well in tribal group, and the government of India has got that kind of an initiative to get the tribal group vaccinated, because the tribal has got a very peculiar social structure. So it may be very difficult for us to make them behave according to the COVID protocols and all. Inside the tribal settlement, they are very much closely associated, and it may be very difficult to change their behaviors. So there will be, if the virus happen to be inside the tribal belt, it may be difficult for us to control the outbreak. So we have finished almost the entire tribal area, at least one dose of vaccination, and we are running with the program to complete the vaccination so that we can protect this underprivileged group. And this is another program. It's a very important program in Kerala to reduce the digital divide. So work along with vaccine equity, that is WAVE. So as you have already discussed, there is a digital divide so that the people cannot register for the vaccination. That is one thing. Second one is in Kerala, the vaccine hesitancy is much less. That is one thing. Another one is vaccine demand is very high, because actively now Kerala is facing a large surge of COVID-19. Compared to any other part of India, Kerala is reporting every day more than 20,000 cases now. So there is a high demand for vaccination. If a slot or a vaccination center is open online for registration, it used to finish off within 15 minutes. So if you are not a computer savvy person, it is very difficult to get a vaccination for you. So government of Kerala is coming with a dedicated program that working along with vaccine equity. So what we are doing is, the ASHA worker, they may be knowing the vulnerable people in this society. They are not able to find a slot through their mobile phones and all. These ASHA workers, they will move out and go to the houses of these people and will help them to register in the COVID portal or to get the vaccination. That is one initiative that it is taking place. And there is Akshaya Kendras. Akshaya Kendras are there in Kerala, all over Kerala. It is distributed in all nooks and corners of Kerala. And Akshaya Kendra is basically, it is a computer center so that you will get, maybe suppose you want to get an Aadhaar card, or you want to get a PAN card, or you want to get a railway ticket or something like that. You can get it from the Akshaya Center. But now the Akshaya Centers are instructed to help the people to get their COVID vaccination registration also. And another important initiative, the comorbidity list. Okay, you know that COVID-19 is not a neutral disease. It is a non-neutral disease. Certain people are affected more. Certain social groups are affected more. Certain epidemiological groups are affected more. Government of India has come out with a list of comorbidities where you can give vaccine priority. But again, added to that, Government of Kerala has given another priority list to get the people vaccinated if they have got a medical problem. We can check the difference, the starking difference between the list prepared by Government of India and Government of Kerala. And you can see that almost all morbidities, if suppose you have got any neurological problem, any renal issues, any liver issues, any cancers, any genetic disorders, even if you have got a diabetes, if you have got a hypertension, suppose if you are getting any autoimmune disease, any rheumatological issues, any endocrine disorders, everything is covered by Government of Kerala. Because suppose obesity also, suppose if your BMI is more than 30, it is also given a priority for vaccination, so that the all morbidities will be covered. And if you are more prone for a severe COVID or death because of COVID, you are getting a priority for COVID vaccination. And a few things were also attempted. And one is, we are mixing the online sport with the walk-in COVID centers. You can get an online spot, otherwise you can go and get the vaccination. That is one thing. We are involving RRT in vaccination process. RRT means rapid response teams, that is constituted at every village level, so that these people can involve in vaccination program. They can mobilize people to the vaccination centers. They can help them in registration of vaccination, and if they can also help them to get the vaccination if there are sport registrations available. And LSGD mediated vaccination programs. Kerala is a place where local self-governments are very active, and the decentralization is taking in a very, very good manner, so that these people, these panchayat members and the elected representatives are given some slots. Suppose in a primary health center, there are 200 vaccination slots are available, and these 200 slots are distributed, or it is divided among the elected leaders, so that the elected leaders can find the vulnerable people and distribute the vaccination slots among them. That is another initiative that is taking place. And the participation of private sector is also very good in Kerala. 25% of the vaccine share is used to distribute through private sector according to the Government of India norms. And if the private hospital is not able to purchase this much vaccine, because there is a criteria that they have to purchase 6,000 doses of Covishield and 2,000 doses of Covaxin, something like that. If your private hospital is not able to purchase that much number of vaccine, Government of Kerala used to purchase and distribute among private sectors, so that the vaccination through the other channel is also open, so that people will get more choices to get their vaccine. So this, I am not going to discuss this thing, but you can see that the infection rate were much less in Kerala compared to any other part of India, if you look at the ICMR surveillance. And we have got a unique experience at Trivandrum. One of the old age homes, because of the program that was dedicated to cover the old age home, we distributed 2 doses of vaccines in every old age homes. But in one old age home, it happened to be a super spreading of breakthrough infections, and no severe cases and no death were reported because of the extensive vaccination. That we are actually documenting that, and maybe in a few months, we may be able to publish it in a very good journal, that we are actually in process of reporting that experience, that if you are able to distribute at least 2 doses of vaccination in your old age homes, Even if these elderly people are more prone for severe COVID and death, we can save these people. And that is another experience that Kerala has got. If we have got more things to discuss, I think we can discuss maybe in the question and answer session. And if there are time, I can discuss now. So I think I have answered a part of your question. Thank you.
Sure. Thank you so much, Dr. Anish. This was a wonderful presentation on, just the meticulous way in which the whole vaccination drive has been taking place in Kerala. On one hand, you mentioned that you're not a model state, but I think in so many respects you are. Dr. Anish, in fact, is one of the members of the Kerala State Expert Panel for COVID-19, and he has been a public health consultant at the Kerala Disaster Management Authority. His research includes communicable disease epidemiology, mathematical modeling of infectious diseases, and health policy. Thank you so much for joining us today, and definitely we'd like to take this forward in the question answer round. I'm sure there are many people who would like to come back to you on this. Thank you, Dr. Anish.
Thank you, Jennifer. Thank you for the opportunity.
Sure. Next, we would like to have Dr. Pankaj Bhatnagar, who is the one second. Dr. Pankaj Bhatnagar is the Deputy Team Lead, National Public Health Support Program at WHO's country office in India. He is a graduate from the Maulana Azad Medical College, New Delhi, with a post-graduation in pediatrics. Dr. Bhatnagar joined the WHO country office as the National Polio Surveillance Project Surveillance Medical Officer in September 99. He has held national level positions in NPSP since 2002 and has been responsible for training, technical trainings, and implementation of a number of strategic interventions in polio eradication and strengthening of routine immunizations. He has also presented several publications on vaccine preventable diseases in peer reviewed journals. So I'd like to pass on the floor to him. And Dr. Pankaj, we'd like to ask you, what are the global experiences show that access to vaccines, and Dr. Anish has just spoken about this, has not been fair and equitable? The current statistics show that the rate of vaccinations in women is far less than men. What are the high priority actions that can be taken to tackle this issue? So over to you, Dr. Bhatnagar.
Okay, thank you. I will just thank you, Jennifer, and good morning to all the colleague panelists, to all the participants who are on this webinar. Is my slide visible? Can I
Yes,
share? Oh,
yes, yes.
okay, I will just go to full view. So I will just try to set the context first. And COVID pandemic, as we all know, has challenged the global health systems, and it's very important that there is an equitable distribution and access to safe and effective vaccines, and that is very vital. Now, since we are speaking about the third wave, and I think Jennifer and Dr. Anisha also spoke about it, we really need to, speed up the vaccination program. And this is a slide actually I prepared for another meeting yesterday. So far, if we are looking at the vaccine doses distributed amongst the population, overall it is, about 7 or close to 8 persons per 100 population have received both the doses. So you can see that we still need to go very much faster than this, and about 27 persons per 100 population have received one dose. And this is how all the states on the left hand side, you have the states in various colors, and you have a couple of states that have given more than more than 40 persons per 100 population have received at least one dose. That actually amongst the larger states, Kerala is doing much better than anyone else, because you can see Kerala has got 42 persons that have received this. And for the 2 doses, actually, we see that Kerala is also reaching about 18. So amongst the larger states, Kerala, like Dr. Anish pointed out, some of the initiatives, I think those are having effect on faster vaccination of the population. Now moving on to the topic, when we go to the vaccination coverage, you can see that on this slide on the right, that Covishield, we have given 426 million doses, Covaxin is about 59 million, but then there is a clear divide between the male and the female. This is 53% of males and 47% of females. Even if we factor in the gender disparity, even then the women in India are not getting equitable number of doses, and I think this we are seeing in the COVID disease also. When we look at the cases, we see that out of the nearly 32 million cases that have occurred, 2/3 of the cases have been reported amongst males, and almost 1/3 are amongst females. But when we see the zero prevalence, there is 69% of females are affected, and about 65% of males, 65.8 had zero prevalence by the ICMR. So definitely the women are getting equally affected or even more affected by the disease, but they are having challenges in accessing healthcare, and probably they are not able to reach. Now, if I go to another slide, and this is prepared from the COVID dashboard, if we look at the vaccination rates by state, we again see this gender disparity. So the dark brown color bar is for the males, and males vaccinated per 100,000 or 1 lakh population, and women is on the yellow, which is again for the same denominator. Now you can see that in almost every state, the women are less well vaccinated as the male. So we really see that this is an issue. When we look at the vaccination coverage by age groups, and we started with the healthcare workers. So about 90% of the healthcare workers, this is where you have more women actually as compared to men, but I don't have the gender breakdown for this. But as you can see here, that there are varying rates of vaccination, because the way it started, it was first the healthcare workers, then the frontline workers, that was followed by those above 60 years. And one of the things that I would like to point out is that vaccination is actually meant to uh, actually prevent death and disability, particularly in this age group of 45 to 60 years of age. And if we look at the coverage, it's less than 60% in both 45 plus age groups, with even the first dose, and the second dose is now beginning to sort of catch up. So this is very important from the point of view of protecting our populations, and from death, disability, and preventing even a third wave. If we look at the vaccination, and on this slide, what I would like to point is actually the registrations. Still many people have not registered, particularly I'm worried about the 45 plus age group, and this includes women as well as men. And Jennifer, I think you spoke about the digital divide, and in one of the studies that we did in Uttar Pradesh amongst the rural population, this was one of the important findings, that lesser number of women were not only vaccinated, and one of the reasons also was that they do not have access to registration, and they are not knowing about this. The other reasons, we are also monitoring, WHO and UNICEF both undertake community-based monitoring, and this is a rather busy slide, but here some of the reasons for vaccination are clearly outlined, and this is particularly for in the bar on the top. You will see the ones in red, dark red, and light yellow. So the dark red is no immunization, yellow is the partial vaccination. And when you see the reasons, lack of awareness and communication is one of the major reasons, about varying between 15 to 20%. And then the apprehension of adverse effects. So that's another between 20 to 30% higher in the older age groups. And then there is some vaccine hesitancy, which again varies from 10 to 15%. So these are the major reasons which are also affecting our vaccination drive, and so which also give us the sort of the action plan while we are formulating, while we want to speed up the vaccination. So as I was saying that about our UP study, particularly we have found that there was a preference for the health and welfare of males over females. The decision-making powers also remain with the male members. I already spoke about the lack of knowledge, the fear of AFI, the gender divide in the technological access to digital illiteracy. So access to smartphones is also less with women. So all these are having effect, and women are being left out in the vaccination. So what can be done? I think that's your question, and I think one of the important things is the communication aspects, and we can also so I'll just stop sharing, and I will just speak from here on. And so one is the very important thing is the intervention that you know, behavior change communication, purporting effective social and behavior change communication to fight these misconceptions and promote the benefits of getting vaccinated. So we clearly saw that there were issues regarding knowledge of vaccination, where to get vaccinated, and another thing that we saw, particularly in the rural areas, when we did that study, it is not the social media platforms that are effective in those areas. And it is there where our frontline health workers or the healthcare workers, like the ASHA, the Anganwadi, the ANMs, they are going to play a key role. And that's where our we still have large populations in the rural areas which need to get vaccinated. And even I would like to say that first we were thinking of COVID as mainly urban disease, but the zero prevalence study, the latest zero prevalence study results have shown that the 69% of urban dwellers have zero prevalence, and 66% of rural India also have zero prevalence. So that divide between urban rural is also being bridged. So it is very important that our frontline healthcare workers, we have to leverage their extensive network. I think Dr. Anish showed very good examples what has been done in Kerala, particularly skill building on interpersonal communication. And this is something we did extensively for polio, for measles, rubella campaigns, and that really helped. The other thing that in my experience works very well is to work with the local level influencers. So one is your elected representatives, women leaders, self-help groups, and they can mobilize. But it's also, I think, if we can reach out to the village level influencers, the pradhans, and even the others, the physicians who are practicing there, and organize, with them, or orient them that we need to reach out to the community, inform them, and particularly, I think we need to have gender sensitive orientation also, so that they realize that the women of this country are getting left behind in getting protected from COVID. Also, the vaccination itself can be organized in such a manner that you are having vaccination campaigns at Anganwadi centers, or reaching out like Kerala. Again, I would say that this was a very good example of reaching out through the tribal communities. I think WHO and UNICEF are also working through TriFed to reach to tribal communities. In Bihar, also we have seen some mobile vaccination centers, special centers like the pink booths, exclusively for women, and that may be again something to look forward to. If we see our vaccination sort of graphs, what you will see on CoWIN is that the vaccination drops drastically on Sunday. Maybe I think that is one of the days where we need to think about having this kind of approach, where like what Bihar has done, that you have a specific day on which you target, you get your healthcare workers have vaccination booths to reach out to women in the community. Targeted campaigns by the civil society can be important activity in urban areas and also in the rural areas. And also, I think when we are training and we are developing guidelines for healthcare providers, I think the gender-based training is also important. I don't think we often neglect this aspect in our training programs, and sensitization is less for gender-based issues. So I think these are some of the important things. Again, I would say a lot of support from the healthcare workers, community leaders. I think also wherever religion is important, and if there are religious, communities getting left out. For example, in polio, we did istamas also for Muslim women. This was to orient them on the health of their children, but here we can orient them on their own health. Uh, Also, I think there may be a need to address women-related health issues pertaining to menstruation, fertility, pregnancy, lactation. Also, we need to engage with the organizations like Foxy, because they will play a big role in ensuring that the pregnant and lactating women who are now under the immunization program, they need to be made aware that vaccines are available and are important, and there is a greater risk if they are not vaccinated. So I think those are some of the important things with regard to what can be done for catching up. And in my experience, it is the district task forces, where the district program managers, like the district magistrates, the commissioners, the chief medical officers, and the other departments and the civil societies can come together and plan for vaccination, and review what has been happening in vaccination. I think they can change the course. In my experience in public health in India, these accountability structures have played a big role in improving our vaccination coverage. And I think we need to leverage these structures for vaccination of women and for improving COVID and routine immunization in the country. Thank you. I'll stop there and you can take questions later.
Thank you so much. Thank you so much, Dr. Bhatnagar. That's a wonderful overview you gave us about, which is comprehensive sort of picture of the demographics of the vaccination drive at the moment, and what sort of challenges we are facing, especially in terms of the gender differences and the gaps that are there. Thank you for letting us know about the ways we can counter this, and bringing in your experience from other immunization drives so that we can learn from that and probably increase our rates of vaccination in women. I think more questions will be there in the question answer round. So we look forward to having your insights there as well. Thank you so much again. Okay, the next person we will be moving on to is Ms. Pratibha Pandey, who's the health specialist at the Child Fund India. Ms. Pratibha Pandey is a public health professional who brings us over 16 years of diverse and rich work experience in the domains of maternal and child health, nutrition, reproductive and sexual rights health, and social development. Ms. Pratibha has worked with various international organizations, including UNICEF, CARE, Family Health International, and Urban Health Resource Center, with assignments in various subsectors of health planning and action. She has been serving Child Fund India as a health specialist for nearly 4 years and was a pioneer in redesigning and giving strategic direction to health and nutrition programs at the organization. We welcome you, Ms. Pratibha Pandey, and I would like to turn the floor to you and ask you our next question, which is with the speculated third wave, projections are that children will also be affected. What measures have NGOs taken in the field of vaccination for children? Also, due to COVID-19, other vaccination programs aimed at infants and children's health have been severely affected. What measures are NGOs taking to overcome this challenge? So, over to you, Ms. Pratibha. Thank you.
Thank you. Child Fund, as you know, we work with children and we are working in 15 states. So, and protecting children from COVID during the second wave and also preparing them for the third wave is one of the main thing which we aim to do. What we and we also target, like we are doing vaccination campaigns for the adults so that the children are also protected, and our aim is to reach to at least to 70% of people getting vaccinated in the locations where we are working. And we are working in around 3,000 villages, which are really very difficult to reach, like working with tribal population, where even the vaccination coverage for the other for other not for COVID, for other also is very less as compared to all over the country. So what I will, the NGOs, as an NGO, grassroots level NGOs, we are observing, and the major challenges we are facing is from both the side, like for the availability and also the accessibility of vaccine for adults is the one main challenge we are facing. For children, since the vaccine has not come, we are motivating the parents to get vaccinated, and we are working at the national level to the vaccine rollout with the government as soon as the vaccine came for the children. So major challenge was during the COVID time was that the parents were not aware, like they don't know that even the child, if they are COVID, what to do. And the children, they were mainly focused, they were mainly feeling that they will also die, because there were so many mental issues we are observing with children in the community where we are working. So what we are finding that whenever there is a parent is positive or the child is positive, there is no way that nobody there, they don't find anybody who can help them understanding that children are mainly asymptomatic and there's nothing much to worry. And also on the second side, because the major focus was on adult, even from the government side and also from other people, also the children were mainly ignored. Children may not be, the COVID may not be very serious for the children, but the impact is very serious, even if their parents are COVID positive, because once the parents they're staying in the same household and there were no separate arrangement for the children. So to what we NGOs we did it, we have prepared the community, the villages, so that whenever there is a positive parent, the children should be taken to those locations, to those places, and those places we are saying is child-friendly COVID care centers, where children who are positive, also in some location where the parents are positive and there is nobody to take care of the children, can be there, and a hand-holding support and proper support is given to the children. We also need to train the healthcare workers, because healthcare workers are not they are not skilled how to handle children or the parent of a child in this COVID time. And other illnesses of children are being ignored because of that, because our primary health centers, who are one of the remotest, who caters to the needs of the remotest children, are overburdened by the COVID-19 patients and also by the adult diseases, other diseases. So children are mainly ignored over there, and they were not trained. Like, there are COVID care centers at the primary healthcare levels, but it's not dedicated to the children, and also the staff are not trained that how to deal with the child patient, or if a parent is coming with the symptom of something like that. So it's completely unfriendly behavior we are seeing. Because of that only, with all the primary health centers where we are working and the partners are working, at the primary health centers, we are making them child friendly. It means that we are training the staff members, and the the like pediatric care centers or the child hospitals need to be child friendly, where the children going there, they do not feel stressed. They should feel happy. Even not happy, they should not be so stressed that we are going to a COVID care centers or something like that. So all the child hospitals are being converted, are in the way of being converted into child friendly centers. And it's very usual that the instrument, the ventilators, or the other medical instrument which are used for the adults may not be used for the children. But it's not there in most of the remotest primary healthcare centers, or even at the community health centers. So it's the lack of even the all these things also. Now I will come to the vaccines, because these parents in the locations where we are working, we want them to be vaccinated. But a lot of issues are coming over there, because one is the shortage of vaccines, because the sessions are not being planned. If you look at the prioritization list, the prioritization of vaccine of session lies with the block medical officer or the district administration. And sometimes, because these locations are far away locations, tribal locations, or hard to reach locations, and even the team find it's difficult to reach over there, they are left out. So here comes the roles of the NGOs, that working with the block medical officer or the chief medical officer, so that the sessions are planned for these locations where the children are more vulnerable, or those locations which are being marginalized. So this is happening. Another thing is that most of us are working on the concept and doing wheels, vaccination on wheels. So it's a van in which it not only provides the vaccination to the people, but also provides counseling services to the children and their parents. So vaccination on wheels is done by with support of government, where the vaccines are available, and the doctor and the nurses, they go to the remotest area, they provide the vaccination to the parents, and telling them that your children will be protected once you are protected. So take these vaccines, and then providing counseling, referral, and other services for the vaccine, for the COVID-19, and this will be going to be continued for the third wave also. And the second part is the working with the private providers. So link private, taking vaccines from the private, and doing these vaccines on wheels to the remotest population, taking over there, and then giving the vaccination services we are. The other challenges we are facing is that the other vaccines which are, because it's a huge country, and if we look at the logistics of dispensing the vaccines to this vast population is a difficult thing. And in all over the country, we only have 30,000 vaccine carriers, so where vaccines are being stored. So managing such a big vaccine stock is a and also managing local inventories is immersively challenging. So other immunization schedules for the children is being being disturbed because of because the COVID vaccines are also stored on that, and it doesn't have that capacity also to so do it. Besides that, the power cut-ups and transmission falls, all these are the major issues which we are trying to address through private companies, because companies, they have customized refrigerators and providing with and tying it with the government so that they can get it, and the COVID-19 vaccines along with the other vaccines can be stored over there, and this issue of vaccine availability can be sorted out. Still, the because children vaccine is not even still is in the trial phase. One is, I think, completed, but even now we found a lot of vaccine hesitancy. So it's a huge hesitancy for the adults in tribal location, because availability is not much. The hesitancy seems to be disguised in all that. So in tribal and rural location, which are hard to reach, the communication, the strategy or the communication is not reaching to them, that how this vaccine is going to save them and their children from COVID-19. So that we are addressing through religious leaders, to all influencers and other influencers who are there at the community village and community level. We also are finding that we also the major finding that there are task forces who are dealing with the post COVID vaccination related issues. Despite that, we found a lot of lack of confidence among people about this vaccine, because there are lots of news, and even the political leaders who are giving irresponsible statements, which really made it difficult for people to believe that this vaccine is really going to work. Uh, I think the transparency is one of the thing which was needed at that time. So, and that what we are doing, like all the report, the trials report, whatever has come out, we are sharing with this community member in their local languages, because most of the things are in Hindi and English, whereas our country is a multilingual country, and people who are at a very remotest area may not be able to read or apprehend whatever is written in the Hindi or English document. So that we are doing, we are converting these into different local languages. We are also doing like community radios in local languages, so that people can understand how COVID-19 is affecting children and how to deal with it, who are the service providers around them, where to consult. All these things we are taking part. So in the last, I will always say that only government cannot deal with it, especially the children. We are being ignored right from starting with in the COVID-19, because we always not feel, but it's right that they are mostly the symptoms are mostly mild and asymptomatic, but the impact on them is very high. Even if their parents are COVID positive, they are very fearful. They feel that they are going to die, even if they have a mild symptom also. So all this needs to be addressed, and it is possible when government works with the private also. So public-private partnership is the only is the most important in this COVID-19, and also the vaccine rollout. We believe in. So, thank you. So.
Thank you so much, Ms. Pandey, for this wonderful presentation, telling us about, giving us insights from the field about how things are progressing with child vaccinations, and for showing us a lot of ways in which we can counter challenges that are specific to children, which include not just making child hospitals child friendly, but also in terms of psychosocial care of children who are facing this crisis in a very different level. And thank you for bringing us all these insights from the field. I will next like to move on to This the last but not the least speaker is Mr. Banku Bihari Sarkar, who is a program officer, risk and resilience, UNICEF at the Bihar State Office. Mr. Banku Bihari is he has assisted the state government in the development of SOPs on floods, drought, fire, and safety of hospitals for improved preparedness and emergency response. He has been instrumental in the development of guidelines on heat action plan, drowning prevention plan, both safety plan, district disaster management plans. He has 20 years of experience in the development sector, of which substantive experience is in humanitarian and disaster risk reduction, including designing, implementation, and scaling up of the DRM model. Mr. Banku Bihari, I'd like to give you the floor. Let me ask you the question we'll be asking you today, which is during complex emergency situations like, for instance, the recent Bihar floods, what are the new challenges that you're facing in terms of vaccinations? So over to you, Shri Banku Bihari. Thank you.
Thank you so much, Jennifer. And before talking about the challenges to the vaccination, it would also be pertinent to understand what are the new challenges or new scenarios which is emerging to all those areas which may be facing floods amidst COVID. And we know that it's not very simple to really deal floods when the COVID is there. And we are also expecting a third wave of COVID. As we know that one of the protocol of the COVID, which talks about the COVID appropriate behavior, which talks about people need to be confined indoors, and as well as they need to avoid crowds, as well as they need not to come out of the houses unless and until it is required. But we know that once there is a flood or any kind of disaster or humanitarian crisis, people will be forced to come out of the houses, and they have to stay in a crowded, maybe unsafe or unhygienic conditions. So that will be definitely a challenge, which we have also seen in the recent Bihar floods, because we have been talking about that it's pertinent to avoid COVID third wave only with following the COVID appropriate behaviors. So that's the one emerging scenario or the challenge. And as we have been seeing that if the flood shelters where majority of the people would be staying during any disaster or floods, so if it is really not managed well, following the appropriate COVID appropriate behaviors, as well as other arrangements are not being made, definitely those flood shelters may become super spreaders. And we also know that there are a lot of actually COVID related interventions are going on, be it identifying people with ILI symptoms, or maybe even the testing, treatment, or care and support, or maybe COVID care centers, as well as the vaccination, which is currently the one of the most important priority of the state government. So majority of these interventions may also get either interrupted or maybe delayed for the regions. So that's why it's very important for us to really understand all these situations which may emerge because of the humanitarian crisis which a state may face. And we also see that a lot of buildings or the space which has actually being used for flood relief centers, maybe those buildings may have been or are maybe being used as a COVID care centers. So there will definitely be a lack of space or building, so which will also again will be difficult for the state government to really manage the people who have been evacuated. One important aspect that also we need to really discuss and understand is that when we talk about vulnerable population in terms of COVID, and when we talk about the vulnerable population in terms of any disaster, both are almost different set of people. And in the COVID scenario, a new set of vulnerable population that has also emerged. Like there may be a huge number of population, a percentage of population who may be asymptomatic. And then there are, as we understand, that there are many states which are reporting COVID positive people. Then maybe there could be some people who are still in the COVID care centers or in the hospitals. There may be even people who are actually like in home isolation being treated at home. And as we also know that there are several service providers who have also been affected with the COVID. And as we also know that there are people who have recovered from COVID, but still there are certain symptoms which they are actually going through. Apart from that, in the COVID, as other speakers have talked about, that we know that the children below the age of 10 years have always been said as a set of vulnerable population, then people with comorbidity or people above 60 years of age. So unless and until we keep these new set of vulnerable population in mind, while we are preparing for any disasters which the state may face. Then we also know that because one of the experience that we faced in 2020 in Bihar, when there was a flooding, and that was an entirely new set of situation which we faced in Bihar in 2020, when we have been facing COVID, and then there was a flooding in the second week of July, and we saw that almost 8.7 million people were affected by floods, out of which government has to evacuate around 3 million people. And what we saw, and it was really surprising for us, only 5% of the evacuated population, they actually stayed in the relief camps. Most of the people actually, they don't really prefer to stay in the relief camps because of the fear of the getting infected with the COVID. So then it becomes different, and they prefer to stay either on the roads or the railway tracks or high grounds. And then it becomes very difficult for the government to really provide them services, safety and security of women and girls. And then as well as it was also difficult for the for government to really make people understand and follow the COVID appropriate norms and behaviors. So and even in during 21 flooding also, though it was not a very big flooding, it was just a flooding which happened in the third week of June, where around 6 districts were affected. Again, we found that the people really are really not reluctant to go and stay in the relief camps. Still, that fear is in their minds. And in some new set of social norms or behaviors which we are expecting people to maintain during COVID. And we know that when they will be going to the relief camps, then the similar kind of actually expectations will have to from us that people actually should follow, be it social distancing, be it putting mask over there, be it sanitizer or hand washing, because we know that there would be huge space crunch for the relief centers. And especially in Bihar, where we know that there is a lack of space for creating flood shelters. Suppose if when there is no COVID, the relief centers may be being occupied by say 500 people. If during COVID, if a relief center is being organized, just 1/3 people may be actually accommodated in a relief camp. Then it becomes difficult for the state government to really multiply the number of relief camps by almost third times or 4 times because of the constraint or the lack of space or infrastructure. And we also see that it's not only COVID appropriate behaviors, but also we need to create a new set of facilities in the relief camps, like regular surveillance of COVID symptoms, and maybe testing also, or isolation treatment, sanitization would be required. Then also we need to bring in or add some new equipments, be it like in the relief camps, we also need to provide them thermoguns or oximeters, masks, sanitizers. Maybe the number of toilets need to be increased. Even the hand washing facilities also need to be increased. So these are some of the challenges or the things that we saw during the floods in 2020 as well as in 2021. And hence it would be very pertinent for those states and others who are actually have not so far faced any kind of flooding or any situation. They need to be mindful of that. As far as the COVID vaccination is concerned, as I said that in some of the areas which got flooded, like East Champaran, West Champaran, some parts of Muzaffarpur, and as well as Sitamarhi and some of the other districts, where definitely COVID vaccination was disrupted for a few number of days. So in those areas, as one of our colleagues from WHO was talking about, the government of Bihar actually started doing some innovations Like they started arrange mobile boat actually vaccination on boat. So where the health workers were actually carrying vaccines on boat, and then they were actually reaching to the areas which were surrounded by water or maroon areas, and then doing the vaccinations. And government of Bihar also, with the support from WHO, UNICEF, CARE, and others, started a Tika Shala vans. That is basically a mobile vaccination, and they have been reaching out to most of the urban areas, going to all the big residential complexes, schools, and other places where there could be a good number of people can be actually brought in. Apart from that, Government of Bihar also tried to do some pre-positioning of vaccines. And then Government of Bihar also did one thing, that they prioritized vaccination of all the government functionaries who would be deputed in the flood relief work. So they were given priority, as well as Government of Bihar also issued an instruction for giving priority to vaccination in the areas which are going to be flood affected. So these were some of the things or strategies which Government of Bihar actually put in place. Some of the things that I would like to suggest as a preparedness or response action which can be taken: definitely pre-positioning of vaccines and other required items need to be planned well in advance, so that we should not be taken by surprise that there is a flooding, and one can't say that because of the flooding the vaccination got disrupted, because we know that there are certain states which may face flooding during the monsoon. So they need to put all these preparedness measures in advance. Second thing, definitely you need to prepare a roster of human resources who would be deployed for the vaccination. And we know that, keeping in mind that several health personnel are also affected with COVID. And we also need to map out all those areas which may get marooned as well as cut off. And these are not certain things that people don't know. These data is still is available with the district administration, and that maroon villages or the cutoff areas, where you need to also plan to have maybe a boat ambulance, or maybe the vaccination on boat kind of things. And apart from that, there could be an alternate plan, as we have been seeing that for polio vaccination, there was always an alternate plan was being prepared to continue the polio vaccination even during the floods or any disasters. So maybe a health department with the support of development partners can also prepare an alternate plan for continuation of COVID vaccination in the flood affected districts. Even the COVID vaccination centers can be placed in the flood relief shelters, where you will get a good number of people who may not have been vaccinated. And as well as we also need to see that the surveillance and regular health checkup for COVID symptoms would be one of the priority during any floods, because unless and until we do this surveillance and as well as regular health checkup, we won't be really able to understand whether the more number of people are being infected, because there could be some people who with the COVID symptoms or maybe asymptomatic people. So they need to be really identified, and maybe they need to be isolated also. And we also need to provide some of the materials which I talked about, maybe thermal scanners, oximeters, and other facilities. And it's also important to regularly review and update the human resource roster, keeping in mind the COVID context, because many health personnel are also being affected. So we can't take for granted that, okay, health personnel are there, frontline functions are there, we can actually review them. And that's why it's very important for regular health checkup or surveillance of health personnel also for COVID symptoms. And they also need to be, their health need to be strictly monitored. And if someone is found with some mild symptoms, even that person should also be immediately isolated. And we also need to see that during floods, if we can also mobile vaccination concept, Tika Sala vans or other means of vaccination can also be put in place. So these are some of the things, Jennifer, that I wanted to share with the audience. Thank you so much, and over to you, Jennifer.
Thank you so much, Mr. Bhankubihari. That was a wonderful discussion on the sort of challenges that have come out especially in the Bihar flood situation, which is again has now turned into a complex emergency. I also am happy that you pointed at all the ways in terms of vaccinations, how you have made all these innovative ways in which you at UNICEF and obviously a lot of government initiatives have tried to come up with ways of reaching the last mile. So thank you so much again for joining us. We would like to get into the open discussion round, which is so if you have any questions, the participants are asked to raise their hand and then we can take the questions accordingly. So we are opening up the floor to all the participants and the panelists, whoever you would like to ask any questions to. Um, so while everyone is starting this, let me begin by asking Dr. Anish a question. Dr. Anish, I wanted to ask you about, you did run us through how a lot of the immunization has been quite low in terms of youngsters. And so what sort of measures are you taking to get the younger generation and the younger population to increase their vaccination rate?
Actually, the problem that we face is the lack of vaccines. It is not our inability to vaccinate, but we are facing a shortage of vaccines. As the vaccination program is going smoothly, the people who are demanding for the second dose of vaccine is very high. Because so many people are waiting for their second dose, they have got a thought process that unless they are not getting the vaccine on the 84th day, the first dose of vaccine is not useful. But that kind of a mentality people has got. So we have to give more priority for the second dose of vaccine because of sociological reasons. That is one thing. And second one, as we all know that the elderly people are more prone for COVID severity and death. So at least 2 doses of vaccine should be given to them to protect them. So these things are actually end up in low vaccination among youngsters. It is not because the youngsters do not want vaccination. There is a huge rush in vaccination centers for the youngsters, but we are not able to help them because we don't have enough doses of vaccines in our hand. So that is a real issue that we are facing.
Okay, thank you so much for talking to us about this. I next want to ask Miss Pratibha Pandey if she could talk to us a little about, this is a question we had asked, but she has not answered, so I would like to bring this up again. In terms of vaccinations, we are facing not just a dearth of vaccination drives in terms of COVID-19, but also in terms of other regular vaccines. There's been a lot of vaccinations in terms of measles, polio, a lot of very regular things that were taking place earlier are now on halt or have been considerably decreased because of how the COVID situation has been prioritized. I wanted to ask you about that because that in itself is threatening kids with a lot of other infections. So we would like your insights on how NGOs and especially Child Fund is trying to counter that. Thank you. I think she has dropped out. Okay, I think she has not been around. If there's anybody else on the panel who would like to take up this question, because I mean, a lot of you have a lot of field experience in what is going on at the moment. So in terms of child vaccinations, the other vaccinations which are actually getting considerably affected, would anyone else on the panel like to take this up about what sort of measures can be taken to counter that?
Yes, so I'd like to comment on this. So if we analyze what happened with routine immunization vaccination in the country, actually early in 2020 when the WHO UNICEF estimates for vaccination came out, and we look at our Penta 3 coverage. So actually it was the first time we crossed 90% coverage with TPD 3 or Penta 3. We reached I think 91%. But then when the coverages estimates came out for 2020, there is a 6% drop, which means that we have the largest cohort of under vaccinated children in the world. So although our coverage has gone to now, estimated coverage is about 84-85%, but we have 3.4 million children who are under vaccinated. So the risk is more from a vaccine preventable point of view. We've done some early analysis, and it appears that once the lockdown started, that was in Q2 of 2020, the number of immunization sessions went down because of the lockdown. Although the government did sort of issue instructions on how to undertake vaccination amidst the COVID scenario. So there were guidelines that got issued pretty early, but I think it was a very challenging time. It was a new experience for the governments, all the state governments, all the healthcare workers. There was no vaccine available at that time for anybody's protection. You only have to rely on just your COVID appropriate behaviors, masking, and all those things. I think it was a very challenging time, and what we have seen is that in some states and even within the states there is variability. Some places the vaccinations just dropped, especially Q2 of 2020 and Q3, and the important thing is that many of the districts have done catch-up campaigns with routine immunization vaccinations, and they have made some kind of recovery. In other places that it may be still being planned, still not undertaken, but I think we need to do something like that, because the impact could have been greater, I think, but because some of the districts undertook a catch-up campaign, it was less, and also because now there has been a second wave, and maybe what we will look at the data a little later, because data from reported data always takes some time in coming in. The administrative data that comes in into HMIS takes some time in coming in, but I think every district needs to make a plan for itself on how to catch up with childhood vaccination. And if there has been a drop, they need to examine the drop. They need to look at it geospatially, which are the primary health centers, which are the sub centers where sessions could not be held or where there was a drop. What we also see is that in some of these places, maybe there might have been some issues with the availability of vaccines, because of the lockdown and that kind of situation that the state and the districts were in. So I think there is a need to take action. I really appreciate that Government of India has issued guidelines or has issued instructions that everybody should look at their data and make an action plan so that we can recover with respect to childhood vaccination.
Thank you so much, Dr. Bhatnagar. There's some questions coming in. I just want to quickly check. So a lot of people are talking about pregnant women vaccinations, and I think Dr. Anish could be probably talking about this, considering Kerala model has also targeted pregnant women. So the question is, which vaccine is safe for pregnant women, and is it safe to get vaccines in the first trimester?
Okay, I can tell about that question. Before going to that question, I have got a comment on the previous question. That sure. Kerala, as we all know, has got a good coverage of childhood vaccination in the country. And whenever the COVID outbreak has happened in Kerala, one of the government orders, the earliest government order is to give childhood vaccination, and COVID outbreak should not hinder the childhood vaccination. We gave the childhood vaccination continuously in areas where it is not in the containment zone. All other areas were given childhood vaccination. Even if the area is in containment zone, when it is relaxed or released, we actually had a program to cover up the missed vaccination and all. But even then, I think there is a marginal reduction in vaccination. That is because people were not able to come out, or because of the fear factor. People may be staying at their home, and maybe a few childhood vaccination might have missed. Coming to the maternal vaccination program, we have got a rapid analysis of data in Kerala, and we have got somewhere around 50 maternal mortality because of COVID-related complications. And we found that giving vaccination is actually life-saving in pregnancy, because pregnancy as such they are prone for thrombotic events and some other complications of COVID. So giving vaccination is actually a strategy that is internationally accepted now. And we have to encourage our pregnant mothers to get their vaccines, because getting COVID may be dangerous for them. Which vaccine, that is, I don't think that is a matter of debate now, because whatever vaccine is available, it will be life-saving. So there may be a marginal difference between two vaccines. I don't want to discuss that kind of academic things. Maybe because of thrombotic events and all those things. Maybe people think that Covaxin may be better, but I think if you are getting Covishield or you are getting Covaxin, whatever it may be, you get your this pregnant mother vaccinated. That is the most important thing. There is no issue in vaccinating in first trimester of pregnancy, because you know that Covaxin is a killed vaccine. There is no live component in it. Covishield has got a live component, but it is actually that of the vector virus. It is not COVID. The vector virus is non-replicating. Technically, that is live, but that is not going to affect the fetus. And there are a lot of studies are coming out that the vaccine components are not secreted through breast milk, and those things are now available. Evidence is there, so there is no need to hesitate to get vaccination for your pregnant mother. Thank you.
Thank you so much, Dr. Anish. That's quite, I mean, I'm glad that we are clearing up a lot of doubts that people actually have, that they're bringing to the forefront right now. There's somebody who's raised their hand. I'm just going to, if you could, 1 second. Altamash, can you get them to...
Hello, can you hear me?
Yeah, yes.
Yeah.
So go ahead,
Okay.
Mebada.
Yeah. Yes.
Sure.
I'm Mebada. I'm with World Vision India. I'm based in Shillong. Okay. So my question is rather concerned. You see, recently I was part of one webinar in my state organized by the health department, and I had raised the same question. I would like to raise it here again, and I hope that someone can answer me this concern, help me with this concern. Actually, it was very interesting to hear in the entire discussion today, talking about child-friendly and child-friendly environment during this COVID crisis. My concern is this. You see, just recently, in fact, 4 of my nieces, they were contacted with COVID-19, and the youngest one is just 8 months old. So my concern was, how can we make the testing child-friendly? The same way, the same environment where my sister was tested, the same process, the same way is being done to my nieces. One is 12 years old, 14 years old, 5 years old, 9 months old. So within the same environment. And what I can see is that the aftermath of that testing. I could see my 5-year-old niece, she, for many days, she got scared. She keeps on crying. And that left me with something, that why can't the health department make the environment more child-friendly when it comes to testing children? So I had raised this question in that particular webinar, and they said that there's no so far there's no module or there's no uh, video that can help health workers to come up with a child-friendly environment when they do these COVID testing to children. So, and I see so many children being affected by that process. It's maybe because it's at home, or maybe even the hospital also, looking at the windows or looking at the doctors and nurses, they get so scared. So how can we create a more child-friendly environment when we do COVID testing to children, so that it'll not leave a psychological impact, negative impact on them? Because this is going to remain in them for a long, long time. Already they're missing out on schools and they're not meeting friends. So what is going to remain in their minds is, seeing people in PPEs, seeing syringes, or seeing this and that is going to remain in their minds for a long time. So how can we make a child-friendly environment to children who have to go through this COVID testing? This is my concern. Thank you so
Thank
much.
you so much, Ms. Lindo. In fact, I really hope you did get to hear Ms. Pratibha Pandey's session on from Child Fund about exactly some of these issues you have raised. I wish she was around. I would have loved to get her to comment about this. But again, I will have to ask the panelists if anybody would like to take this question up at the moment.
In some countries, they made it easier for testing by doing even the sputum tests. So it's easier and more friendly. And what I understand is that there is no significant difference in the sensitivity or specificity of the tests. So that's one. The other one, I think your question also relates to the environment, that we have in our hospitals, and which should be more child friendly. I think that's what you are referring to, and it's not easy sort of answer, but I think many what I see in the private sector particularly, they've tried to make wherever pediatric cases are going, they've tried to sort of have a more child friendly sort of place, where relating to children, either there are animals, cartoon characters, paintings, things like that. So the atmosphere is slightly different, explaining to the child. What I can share a personal experience. It's when I took so I am also a grandfather. So when I took my 3-year-old grandson, I had to get him tested twice for COVID. We said, it's just like, we are clearing your nose or something like that. The same kind of buds, these are their Johnson buds or something like that is available. It's just like that. It's not going to hurt you. So I found that he accepted it much better than he otherwise. Young children are always scared when they see a stranger, and always there are certain other guidelines. When you are dealing with children, deal with them in the presence of their caretaker, which is usually the mother, and don't hesitate to explain, even if the child is small, what you are going to do. Sometimes people just want to, especially the healthcare workers, just want to get hold of the baby and just do the test. But if the baby is able to understand the next few steps as you are going to approach the child, it may help to overcome the anxiety. That is what I would say at this time. Thank you.
Thank you, Dr. Bhatnagar. Yes, a lot of questions coming up in terms of comorbidities. And I would again bring this question to Dr. Anish, because he has spoken about how the Kerala experience has been. So somebody is asking about HIV patients having more risks because of the vaccine. Are they compromised in any way by taking the vaccine? Somebody else has asked about cardiac diseases and if they can be vaccinated. And thirdly, somebody else has talked about a pregnant woman who has had her first dose before she gave birth, and then she's had the baby, and now how long does she have to wait for the second dose, and if there's any variations in that. So, Dr. Anish, I would like you to answer this question, considering the Kerala experience, which you have pointed at.
In an epidemiological standpoint, we have to take a decision based on the risk-benefit analysis. If you have got a comorbidity, let it be HIV or cardiovascular disease or whatever it may be, there is more likely that you will be severely affected by COVID if you are infected. So that we have to keep it in your mind, that COVID is a non-neutral disease. It is not behaving in the same way for an youngster who is not having a comorbidity and a person who is comorbid and elderly. It will be different. The entire picture will be different. So suppose if you have got any kind of comorbidity, you may be severely affected by COVID. To prevent that, you have to take vaccination. Interestingly, vaccine side effects, especially for the vector vaccines like Covishield, which is widely distributed in India, is having more side effects in youngsters without comorbidity than elderly people with comorbidity. So the vaccine is tolerated by the people having comorbidity, and the AstraZeneca group has come out with a separate paper on that, how the comorbid people are tolerating Covishield or the AstraZeneca vaccine. So definitely we have to get vaccinated, and it is whatever it may be, the comorbidity, whether it is HIV, heart disease, diabetes, or whatever it may be, you consider that as a priority group to get vaccinated. You have to get the vaccination as soon as possible. That is one thing. Second one is regarding the pregnant woman. Sometimes you have taken the first dose in the early pregnancy. In meanwhile, you have delivered, and the time duration might have crossed 100 days or 120 days. Doesn't matter. You have to take the second dose as soon as possible. The breastfeeding or something like that, it is not a hindrance for getting a vaccination. That I have already mentioned, that the vaccine components are not secreted through breast milk. That is one thing. And it should not, do not have live components of COVID, SARS coronavirus 2 also. So it is very safe in pregnancy, and it is very safe in lactation. Even though the duration is slightly more, you can take the second dose whenever it is available.
Thank you. Thank you so much, Dr. Anish. I think these are about all the questions we have for you. I want to give the vote of thanks to all our panelists. I would really like to thank all our eminent panelists for once again taking time on a Saturday to come and enlighten us with your views, and amongst competing priorities to come down and take time with us. You've brought in a wealth of expertise. Your wealth of expertise has really helped us. You've shared insights about the new challenges that have come up, and especially with respect to third wave. You've brought us insights from the field. And a lot of best practice models and case studies. We've just spoken about the Bihar experience and the UP experience, and of course the best practices coming out of the Kerala model. We have also talked about interventions in behavioral changes and roping in multiple stakeholders that can help us, take care of these challenges. Thank you so much for again doing this. And I also want to thank the participants in this program who have come down. Also, it's because of you that we can actually do a successful session. So I would like to thank you for also coming and joining us. Thank you again to all the panelists, and we wish to be in touch and have you again with us at some other point. Thank you. I call the meeting to a close. Thank you so much.
Thank you.
Thank you. Thank you very much.
Thank you.
Sure.